Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. This episode will discuss concepts pertaining to the ear and temporal bone for the core exam. I will make a free downloadable study guide on this topic available on my website, theradiologyreview.com. So go ahead and download that free study guide if you think that will be helpful for you. Depending on when you listen to this, discount codes may be available on my website that may save you money on things like question banks and other educational resources. As these can change over time, please check theradiologyreview.com to see currently available discount codes. As always, if you have suggestions pertaining to topics that you would like to hear discussed, please email me at theradiologyreview@gmail.com or contact me on Twitter or Instagram at RadRevPodcast, and I will do my best to make those topics available. Without further ado, let's get into the questions and answers for this episode. First question, what are the 4 anatomic divisions of the temporal bone? Anatomy is high yield for the ABR core exam, including especially the anatomy of the temporal bone. The 4 anatomic divisions of the temporal bone I am referring to in this question are the squamous, petrous, and tympanic divisions of the temporal bone. And if you count and say there are only 3 listed there, that is correct, because the mastoid is formed by the squamous and petrous portions of the temporal bone, but is often considered an independent portion as well. So the 4 I am referring to are the squamous, petrous, tympanic, and mastoid portions of the temporal bone. Further pertaining to the anatomy of the temporal bone, there are 3 main bony projections that exist that you should be aware of. The first is the styloid process, the second, the zygomatic process, and finally, the mastoid process. Also, in terms of the ear, the temporal bone contains the medial aspect of the external auditory canal, the entirety of the middle ear, the inner ear, and the internal auditory canal. Next question. What are the primary bones, muscles, and nerves of the middle ear? The primary bones of the middle ear should be familiar to you, and that is the malleus, incus, and stapes. The primary muscles of the middle ear that I will mention here are the tensor tympani and the stapedius muscle. And finally, the primary nerves of the middle ear are the chorda tympani and the Jacobson nerve. The tensor tympani muscle is innervated by V3, whereas the chorda tympani is associated with cranial nerve 7, commonly termed the facial nerve. The chorda tympani courses through the internal acoustic meatus with the facial nerve, travels through the middle ear along the tympanic membrane, and courses between the malleus and incus, eventually exiting the skull through the infratemporal fossa to join the pathway of the lingual nerve. Note also that the Jacobson nerve is also termed the tympanic branch of the glossopharyngeal nerve. If you would like to review all of that in writing, go ahead and download the free study guide to review that. Also, reviewing some images online of the anatomy of the ear and the temporal bone may be worth your time in order to better prepare for the core exam. Next, what are the primary anatomic divisions of the cochlea? The cochlea contains a bony ridge called the promontory, the modiolus centrale, which contains the cochlear nerve and spiral ganglion, the apex, also termed the cupula, C-U-P-O-L-A, as well as the basal turn and the cochlear aqueduct, which contains the perilymphatic fluid. Remember that perilymphatic fluid is contained within the cochlear aqueduct, whereas endolymphatic fluid is contained within the vestibular aqueduct. Next question. What are the names of the 3 semicircular canals? The 3 semicircular canals are termed the lateral, or sometimes horizontal, the superior, and the posterior semicircular canals. There is no medial semicircular canal. That can be important to remember for multiple choice style questions. Each of the 3 semicircular canals are positioned approximately 90 degrees in relation to one another, and the function of these semicircular canals is to detect rotational acceleration. Next question. True or false? The internal jugular vein courses through the posterior temporal bone. The answer is true. The internal jugular vein does in fact course through the posterior temporal bone. Next, the geniculate ganglion is part of which cranial nerve? The answer here is the facial nerve. The geniculate ganglion is located at the first genu of the facial nerve in the petrous portion of the temporal bone. I think those are the anatomy questions that I have in this episode. This by no means is a complete review of the anatomy of the temporal bone, and I want to put in a plug here to review the temporal bone anatomy in detail. It is complicated. It's something that's hard to remember over time if you're not seeing it with regularity, but it is something that is high yield on the core exam. Go ahead and find your favorite neuro textbook that describes this. There are plenty of good resources online as well. Okay, next question, and now we're getting a little bit more clinical and less anatomical. What is Ramsey-Hunt syndrome? Ramsey-Hunt syndrome is when varicella-zoster virus reactivates within the geniculate ganglion, causing shingles of the facial nerve. Ramsey-Hunt syndrome presents with the classic triad of facial nerve palsy, ear pain, and painful vesicular rash of the external auditory canal and pinna of the ear, as well as the tongue and hard palate. Sometimes this syndrome can also affect the vestibular cochlear nerve, which is cranial nerve 8, and if so, that would also present with tinnitus and possible hearing loss. On imaging, look for abnormal facial nerve enhancement. Next question. What are the classical clinical symptoms and imaging findings associated with aberrant internal carotid artery syndrome? Pulsatile tinnitus, otalgia, and conductive hearing loss are some of the classic clinical symptoms of aberrant internal carotid artery syndrome. On imaging, look for an enhancing vessel in the middle ear, lateral to the cochlear promontory, with flow voids on MRI and avid arterial enhancement. This syndrome of aberrant internal carotid artery is most common in females and is most commonly located on the right. The vessels that typically enlarge to form the aberrant internal carotid artery are the inferior tympanic artery and the carodicotympanic artery, but that level of detail may be beyond the scope of the core exam. A persistent stapedial artery is also an association of an aberrant internal carotid artery. Next question. What are classic features of a persistent stapedial artery? A persistent stapedial artery arises from the petrous aspect of the internal carotid artery and crosses the middle ear. This normally regresses, but if this is persistent, this can also cause pulsatile tinnitus, as well as conductive and sensory neural hearing loss. A persistent stapedial artery has risk of causing hemorrhage during ear surgery if it is undiagnosed at time of surgery, and can be seen on otoscopic examination in many cases, so this is not always something that is purely identified on imaging. Next, and this is a related question, I told you that both aberrant internal carotid artery syndrome as well as a persistent stapedial artery can both cause pulsatile tinnitus. Name some additional causes of pulsatile tinnitus. Pulsatile tinnitus and conductive hearing loss can also be seen with entities that include a lateral dehiscent jugular bulb, in which the dehiscent jugular bulb has direct communication with the middle ear. Other causes of pulsatile tinnitus include masses, such as a hemangioma or paraganglioma, a vascular aneurysm, or an arteriovenous fistula or malformation. Next, what are classic clinical and imaging features of a congenital callisteatoma, which is also sometimes termed an epidermoid of the ear? With a congenital callisteatoma, look for a mass with fluid signal intensity with non-enhancement internally, but possible peripheral enhancement. This is classically located about the petrous apex in a child with conductive hearing loss. Corresponding bone destruction may or may not be present on imaging with a congenital callisteatoma. Note that callisteatomas may be congenital or acquired, and acquired callisteatomas often result from tympanic membrane perforation. On MRI, look for imaging features similar to epidermoid cysts that include low T1 and high T2 signal with no enhancement of the mass itself, but possible thin peripheral enhancement may be seen. Next and final question for this episode. What are classic clinical and imaging features of a glomus tympanicum paraganglioma? Glomus tumors are high yield for the core exam, and there are multiple types of glomus tumors, not all of which I will review here, but all of which you do need to know for the core exam. A glomus tympanicum paraganglioma is more common in middle-aged females and is the most common middle ear tumor. When I say things like the most common tumor at any site, that should get your attention because the core exam, believe it or not, does tend to focus on common entities, and common entities are more likely to be tested than the very rare uncommon entities, although this is not exclusively the case. But in this case, glomus tympanicum paraganglioma, as the most common middle ear tumor, does rise to some importance in terms of potentially being tested on something like the core exam. Clinical symptoms include ear pain, pulsatile tinnitus, again, as well as conductive hearing loss. On imaging, look for an enhancing mass lateral to the cochlear promontory that may encase or possibly even destroy the ossicles of the ear. Unlike a glomus jugulare paraganglioma, which is often associated with a dehiscent jugular bulb, the jugular bulb will be intact with a glomus tympanicum paraganglioma. The jugular bulb will classically be intact with a glomus tympanicum paraganglioma. That is a fairly dense episode, albeit a minute or two shorter than many of my episodes have been. It might be helpful for you to give this episode a second listen to help drive home some of these concepts, as well as to review some of these concepts in writing, which you can do by accessing the study guide at theradiologyreview.com. Remember that I have other free content available at theradiologyreview.com. That includes several articles in the Radiology Review Journal. I recently posted a short interview that I conducted with Dr. Amy Patel, who has been extremely involved in advocacy and has had leadership roles and made a great contribution to many radiology organizations. If you are interested, check out my interview with her, as well as other interviews I've conducted and other educational materials at the Radiology Review Journal. Thank you for listening to this episode. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode.